Welcome to Vital Times, the podcast series for the California Society of Anesthesiologists. I'm Dr. Ludwig Lin. The series aims to highlight clinical and social, economic, and cultural issues that impact the perioperative experience for both the anesthesiologists and patients of California. Today, I'm grateful to be able to discuss and learn about maternal healthcare disparities and inequities with a panel of expert physicians whose passion project is maternal and neonatal health. Dr. Mofya Diallo is a pediatric anesthesiologist at Children's LA, USC Keck School of Medicine, and a mom. In addition to caring for children, she's passionate about advancing health equity and improving the working environment for anesthesiologists, especially women and those who have been historically excluded in medicine. Dr. Amanda Williams is the medical director at Mommy, a maternal healthcare company dedicated to improving health equity, and clinical innovation advisor to the California Maternal Quality Care Collaborative, and adjunct faculty at Stanford University School of Medicine. Dr. Jennifer Lucero serves as the Associate Dean of Admissions at David Geffen School of Medicine, UCLA, and is the Vice Chair of Justice, Equity, Diversity, and Inclusion in the Department of Anesthesia. Her clinical specialty is in obstetric anesthesia. I would like to welcome and thank all three panelists, and let's get started. My first question for you guys is, let's think about healthcare disparity when it comes to pregnant women and their neonates. What are the things that we all need to know in terms of demographics, data, outcome, as we go forward in this discussion? I'll let you guys speak.
Well, I'll go ahead. It's Amanda. I'll go ahead and get started with that one. So, when we're thinking about health outcome disparities, we have to think about the maternal deaths. We have to think about severe maternal morbidity, things like C-sections. They are all going to be increased for both Black birthing people and Native American indigenous people in the United States and in California as well. One of the things where people kind of go off track a bit is the first thing that comes to mind is, especially the anesthesiologists, comorbidities. They were obese, they had hypertension, they had diabetes. But even when you adjust for comorbidities, in the state of California, which is the best, incidentally, the best in terms of maternal mortality in the United States, there is still 3 times the rate of maternal death for both Black and Indigenous birthing people.
Thanks for pointing that out, Amanda. I couldn't agree more. And that is one of the things that we keep talking about, because we do hear that as, oh, they had these other comorbidities. And there have been studies after studies that control for that. And I think it's really important to drive that point home, that even controlling for all these other comorbidities, we still see this. So we have to ask ourselves, why is this still happening? And, many of these, the mortality rates, they're preventable.
Absolutely. You know, I'm a member of the Pregnancy Associated Mortality Review Committee for the state of California. And so I am in those people's charts. I mean, it is mind blowing to see how the extent to which so much of these deaths could be preventable. Nationally, the number is around 80%. And in California, it's about 50, depending on somewhere between 40 and 60, depending on which cause. So there are things that can be done. Another piece of this puzzle is education and income. So both of those studies were done using data out of my institution, out of the California Maternal Quality Care Collaborative based at Stanford, which matched tax brackets, so the highest income groups for Black women in California still had double the rate of mortality, and their newborns had double the rate of mortality compared to their white peers. So this is not about comorbidities. This is not about education. This is not about income. We have to, at the end of the day, start facing the fact that systemic racism is a part of the practice of obstetrics in America and obstetric anesthesiology as well.
This is
Those are stunning figures. Sorry, Mofya, please go ahead.
Okay. I was just going to say, both of you are pointing to the fact that we are not taught to think of social determinants of health, right? And how we sometimes are not taught about our own bias. We all become physicians after the age of 20. We've all formed our opinion of what people should be. And unless we're taught to check our bias and how we perceive our patients and how we treat them and how we make them feel, and understand where they're coming from, we carry on the biases that we have grown up with, and they actually have an impact on survival and life afterwards. And the other thing is that our patients are actually looking at these numbers. They're reading the articles in the New York Post and New York Times about mortality in women, especially Black, Hispanic, Native American, and Hawaiian women. And they show up to the hospital expecting to be mistreated. And if we prove them right, they're less likely to look for care or ask the questions they need to ask. Yeah, so very important. And it's not protective if you're educated or wealthy, is what you're saying. And there's so much data to show that. So it's a huge problem, and we need to talk about it so we can start working on it.
Mofya, I wanted to ask you a little bit more about the pediatric population. Amanda's already said that the morbidity and mortality for neonatal outcomes is worse. Do you have more data for us, or more thoughts?
So my thoughts on this, and there's data on this, is that it is actually apparent even in pediatric population and studies, even intraoperative care, which we tend to standardize, right? How you get pain medication, antiemetic, right? We still see disparities in how children are treated. So even if we care about children and take care of them when they show up in the emergency room and whether they go to the operating room, the level of reoperation or failure of surgery is higher in minority children. And there was actually a study recently that looked at otherwise healthy children showing up for tonsillectomies and adenoidectomies, that it didn't matter the child's income or education, or the parents rather, that it still ended up that the kids who were minorities, Black, had higher morbidity and mortality after tonsillectomies and adenoidectomies, which are pretty standard and common surgeries in children, right? So
Yes.
it's definitely not something that's not happening in children as well.
I wanted to just repeat what Amanda had said about the mortality figures, that 50% of them are preventable in the Californian population and 80% are preventable in the United States overall. I just find that quite galling. We should not have numbers like that. How are we in America performing compared to the rest of the world?
Well, we are absolutely the worst in terms of industrialized, or you might say economic peer countries. So, for example, the US pregnancy associated mortality ratio, so that's the number of deaths in the year around, during, and after pregnancy per 100,000 live births. That's typically how that number is calculated. In the US is around 33. In Sweden, that number is 5. So, almost an order of magnitude difference compared to European countries. And if you're a Black American, that number is 69. So we're talking about truly, truly appalling acceptance of maternal deaths, particularly for birthing people of color.
Wow. So let's delve into this. Let's talk about the potential reasons why this is occurring. So I would like to discuss potential biologic factors, although what all three of you have basically already said is that this is not due to biology or comorbidities. So are there biological explanations for these differences in outcome? If not, what are the other reasons? Is it the bias in the prenatal care? Is it bias in the delivery room? Is it on labor and delivery? Is it that there is not enough antenatal care? What are the impacts of just a lifetime's worth of health disparity? I wanted to see if any of you were willing to also discuss this phenomenon called weathering of the women involved. So maybe I could get Amanda to start us, and the anesthesiologists should definitely jump in terms of, our in-hospital care.
So, Ludwig, this is my life's work. So I could talk about this all day long. But there are many, many factors at play. And even though these disparate rates do persist after adjusting for access, after adjusting for income, after adjusting for comorbidities, that's not to say that those things aren't a factor. So, yes, more obesity, more hypertension, less access to good prenatal care. Those things are a factor, and that does not give the full explanation. So, not to go off on too much of a tangent, but that's why standardization of care, systematic responses to hemorrhage, to hypertensive emergencies, to cardiovascular collapse in the OR, these sorts of things do help us move somewhat towards equity. And we know that from our CMQCC toolkits and workflows that we've rolled out all over the state of California. But it does not explain the whole thing. That's why we can't pat ourselves on the back too much and say, okay, great, we're better in California than anywhere else. All done, let's go home. No, we still have a 3x rate for Black birthing people and their Indigenous sisters. And so that's not okay. We have to start looking at systemic racism. Now, doctors and nurses are good people. I am one of them, and I am surrounded by them. And they're awesome. For the vast, vast majority of the time, they are not intending to do the wrong thing. They're not running around with the t-shirt on that says, I am a bigot. What they are is living their lives in the United States of America, which is a country imbued with discrimination, with colonization of the native people 500 plus years ago, enslavement, Jim Crow. There are messages in our society about whose voices matter and whose don't. And the voices that matter are not those of brown and Black women. And that's why, I so appreciate what Mofya was saying about even children. I mean, I'm sure that those doctors and nurses are not intending to harm children, yet we are part of a racist society. And so, therefore, we have to deal and start thinking about our own implicit biases and how those are interacting with the care that we're giving, even if it's not intentional.
Let me ask you to elaborate on this for a brief second. When we're talking about implicit bias, and of course it's there, is it a error of omission, or is it an error of, I don't know what the other one is, like not listening? I've seen data that kids with sickle cell crises, for example, or like you were saying, post-op from like tonsillectomy, are not listened to as much when they're not white. So is it that we're not listening to pregnant moms who have symptomatology, or is it that we're not looking and not picking up risk factors? Or does it not matter? So let me
Both.
just ask you to elaborate on that.
It's both. It's both. I was going to just add this to what Amanda said about we're not, I like the term, like, we're not running around with like shirts that say I'm a bigot, but I think what we don't own is the process of, there's a concept that's called aversive racism, which is part of that implicit bias. There's, studies after studies that have shown, when white doctors are talking to their Black patients, they don't spend as much time. They don't, talk to them in much detail. There is also, this mistrust, and for good reason. And so compliance is different. Like, there are, physicians, when a patient is looking for a physician, they know the numbers, and they know when they walk in. It's terrifying for them to walk in and think, one, my pain might not be addressed, I may die, I may, hemorrhage, I may have a headache and get a stroke. And so they already know that, and they're looking for providers that look like them, that understand them, that are part of their community. And I think that's a really important part of what, when we think about the bias that we have, any provider needs to own that they have these biases. Every provider does, regardless of their race or ethnicity, has these biases. They have to understand what it is, and then they have to understand when they're in the middle of, they're tired, they're on call, they're, managing lots of things. That's when the implicit bias comes up. That's when we see the aversive racism. And so they have to stop for a moment, and they can't ignore, they can't pretend, they can't, feel insecure about it. This is, as Amanda said, decades of, years of institutionalized racism that has been set up so that we see these disadvantages, and we're not going to make a change. I know we had talked about in a prior podcast the idea of the long game, and the programs that we put together to really increase the number of physicians that come from underrepresented groups. And that's important because, what we see on the outcome of it is better healthcare for our patients. And that's a really critical part that I think we have to understand. That's one part of it. The other part is really educating the current physician workforce about what this means. And I think one of the things that, just to touch on also, which is part of California, the rural community, we see huge amount of disparities in the rural community. And that's another part that we need to pay attention to, clinics closing down, hospitals closing down. I mean, this is tragic when you think about, what those numbers are even more elevated when it comes to rural communities. And there are a lot of those individuals that are part of these groups, the Black, the Indigenous, like those groups are being impacted because they're in these rural environments. And we're not I don't think we have a plan. The health system in America doesn't have a plan to deal with this. We're closing down clinics. We haven't even talked about the reproductive choice part of it as well.
Oh gosh, I mean, there's so many different things, like you said. And Jennifer, what you were saying about all of us as physicians and other healthcare professionals needing to own this and to have responsibility for listening to these patients. I just think so many of us are at the end of our ropes, on a daily basis. And that burnout and that inability to sort of give more, that's going to have an even worse impact on all of this, because who is going to give more when they themselves just don't have that capacity anymore? I think this is actually a really good moment for me to ask Mofya to give some input, and I really want Mofya to get a chance to share with us her own personal experiences in terms of all of this. So Mofya, you're on.
Okay, so I like what Amanda said about our health system and why we're doing so poorly amongst Western countries. When you look at what the European countries did, and when it was still the EU, EU still exists, but when they were trying to improve maternal outcome, they looked at other things that impact women and children surviving, especially around birth, and they made systems change. Some countries like Germany, after like 35 weeks, you're not really supposed to be working, for instance, right? And they also implemented a way for women to keep their salaries and jobs for a year after a child is born. And they looked at pre and post survival of women. They found cardiovascular events were much lower in women, and children did much better, survived their first year. Their mothers didn't die. This study also looked at husbands and or fathers, and they didn't show any difference. So I don't know if it meant that men didn't necessarily have cardiovascular events related to the birth of a child and having a child, but that is what is behind why European survival around having children is better for women and the neonates. We in America are unable to do those things because we actually need governmental support to actually institute something like prenatal time rest so that you actually are able to survive and have a healthy baby and also support that baby postnatally so you recover and the child recovers or grows appropriately, or even having a partner be able to stay home and help. That's also an option in European countries. They give you a year where you keep your employment, but you could share it with your spouse or partner where you both have 6 months with the baby, right? That decreases the amount of stress. And there's also typically a way of nursing support to come and visit in the home to teach parents how to be parents or how to care for a baby. We don't have all those resources, or they're kind of not standardized. So if you're in a community or a state that has that as part of the community, you can have that access. So if you're wealthy enough to afford nursing to come into your home to help you, or if you have family support, right? It's very haphazard. And we're very individualistic, nuclear family oriented in America. So if it's just you and your partner and a baby, you have to figure it out. You go to the OB 6 weeks after birth, right? And when you take your baby for their first visit, they check to see if you're having a mental breakdown. They give you a little mini mental test. And hopefully that catches that maybe you're having a psychotic break from having a child, right? So all those things, we need a system that catches everything. We don't have that. We're not near that. The other thing is I had the fortunate or unfortunate experience of being also a birthing person in America. So I have a public health degree. I knew the numbers. It was quite surreal to be experiencing what I'd read about, right? I guess education and having insurance did not necessarily protect my experience from either, let's say, not being listened to, right? I had IUGR where you could see progressively my first child was getting smaller as she's supposed to be getting bigger. And I asked for a letter because I needed to be to present a letter saying I needed to hold off some of my clinical duties. As we all know, anesthesiologists push beds, move children. We're always on our feet, right? We work 60 to 80 hours a week, depending on where you work. And my OB said, physicians have small children, small babies. And that was it. And she did not give me the letter, right? I went back, and eventually, by the time they gave me the letter, was a bit too late. The baby came the next week. So it's things like that. And I said to myself, I'm a physician. I have health literacy on my side. I have good insurance, and this is happening. My heart hurts for anybody who doesn't even have the resources or even the capacity to say something, right? Even postnatally, pain management was something where I had to advocate for myself. So, multiple opportunities for me to really see that in addition to being a physician, I am a patient and I'm still mistreated. And I, I don't know why I would have expected something different, but that is also a bias, right? You think, oh, well, I'm not limited income wise, I have education, things would be fine. And it didn't matter. I was at one of the best hospitals and it didn't matter. So I can definitely anecdotally attest that this is a thing and it is in the literature. And I think it's important to listen to our patients. I think that as anesthesiologists in the OB world and in the children's hospitals, we definitely are the group of people who also focus on outcomes. I always say we should own the outcomes that the surgeons and OBs are having, because that is the only way we get to really, really, really interact with patients. If they don't have procedures, right? Unless you're a pain physician, we don't get to meet them. So if a surgeon has outcomes that are terrible, that's how people recognize anesthesiologists. So if we're going to help health equity improve, we need to say, okay, what can we do differently? How can we reduce the impact on health disparities and advance health equity?
Thank you so much for that. So I really want to break this down into the various stages of a mother's journey, because we are talking about the in-hospital experience, which is where most anesthesiologists get the chance to help out. Let's cover that first, but then I definitely would like to visit the prenatal aspects of this and talk about this as a public health issue, and maybe even brainstorm about how anesthesiologists do get to contribute in terms of the public health aspects of it. But let's talk about the intrapartum, or, for sure, the in-hospital aspects of this. What do you guys think are different ways that the anesthesiologists can help? We're around. Most tertiary care hospitals, their labor and delivery suites are swarming with, well, maybe not swarming, but have a lot of anesthesiologists. We're there all the time. So we're available, and we're available as consultants on, like critical care issues. So please help us brainstorm about how we can contribute.
I can jump in here speaking as the OB anesthesiologist. I
Excellent.
I really I approached it, I was the program director for our fellowship, and I looked at it from the perspective of we were going to train OB anesthesia intensivists. And what I mean by that was that we were there to make sure that our patients delivered safely and were cared for, and expect, as I said, OB is predictably unpredictable, so we needed to be prepared for that. And where do we help? I mean, we help in that we're there to assess any sort of complex issue, or if the status has changed, to make sure that we're there for the acute issues that come up that weren't expected. But we also need to, be there for pain control, and acknowledge when pain control isn't working. We can't just, pretend that it's working, or I just think the epidural is working, or denial is a very big thing, and what I always tell our fellows is we need to respect the pregnant airway, but not fear the pregnant airway. And oftentimes we get so nervous, and I would see, people say, oh, I don't want to intubate them. But, if the epidural isn't working and you're doing a C-section, you need to do something else if you're in the middle of the C-section. So, own that. It's not, things have to change. You have to be flexible. Or trying to make something work in a situation where, when you have a patient that's having a second stage C-section, they have the ability to be an incredibly morbid procedure. Be prepared. Know that that's the case. Plan for that. Everything goes well, great. But they can hemorrhage. There could be challenges with delivering the baby. These are so many different things that, you have to be aware of that and plan for that. It doesn't mean that you have to put central lines in every patient, but you have to know, take a look, access, what do I have? What are my plans? Do we have blood? If we need blood, how quickly can we get it? Especially if we're in a hospital where we have limited resources. The other thing that I'm just going to say generally about the labor and delivery unit, it is like a mini hospital. There are sick patients that are antenatal patients that are being watched. There is an operating room. There is an emergency room, which is the triage. There are patients that are actively laboring. That should be the place that we have every single opportunity to have, whatever we need for any emergency. And most of the time, things can go just fine. But it often feels to me that the state of the art things are in the main OR, and somehow we've forgotten that there is patients up it's a whole nother like mini hospital is what I would tell. Like we have to be staffed right. We have to be, supplies have to be fixed. We have to redo all of the operating. Everything needs to be what it would be like if I was down in the main OR. And many times I argue, this is not just some ancillary place. And, the point that was made by Amanda is women are dying from preventable causes. An extraordinary amount of women, over 60% of these deaths were preventable. And we're just sitting there saying, let's make a go of it. Like, no, we just need to really supply as if it is a cardiac unit. Like, have the state of the art, whatever is available. We need to have the latest machines. We need to have ultrasounds. It's hard to get when you have a patient that's hemorrhaging, you need to get IV access. I need to have an ultrasound. I need to have an ultrasound that lives there. That's my ultrasound. I need to be able to, have providers that can do POCUS, point of care ultrasound if we need it. So I think that's the part where we have to. It is, and many times things go well, but there are groups where things, as we're talking about today, where they don't go well and they're preventable. So be prepared for, the worst, hope for the best, but have all of the state of the art, especially if we're in a city, a big city. Now, rural is, we got to deal with that issue, and that's a whole nother issue. But there are institutions that are right in the middle of major metropolitan areas. And if you go to their labor and delivery unit, it doesn't have the same equipment, let's just say, or the same state of the art things if I walked into a cardiac room. And I would say our patients that are young and healthy patients, they deserve just as much as our patients who are getting cardiopulmonary bypass, that are in their 70s and need stents. Like, why don't we demand the same as them? And that is the opinion that I have, and I continue to like talk about it to whoever will listen.
I
Well,
love
one
that.
might
That's
argue,
actually, oh,
Jennifer.
sorry.
Oh, sorry. One might argue that there's a lot more lost life when you have a young, healthy woman who
Yes,
is at
yes.
the brink of losing it. I really appreciate what you say about resourcing and preparation, because everything we do is basically a test or an assessment. And you have to constantly think, what is the pre-test probability of a poor outcome? And if you are walking in the room and you're seeing a patient who is obese, hypertensive, and non-English speaking, and indigenous, like, that pre-test probability, the bad outcome is that much higher, and therefore you need to be more prepared. So constantly thinking about actually what is this person's risk of severe maternal morbidity or mortality is really helpful. I also want to come back to listening. That is one of the most important things that I think anesthesiologists can do to support the OB experience, because a lot of people aren't really equipped to deal with the discomfort of labor. They're not really equipped to deal with postoperative pain. It is one thing to do something in a Lamaze class. It is another thing when it is in your body.
Yes.
So, really listening and trying to get one's ego out of the way. Because especially if somebody's epidural is not fully managing their discomfort or managing to the level of the person's expectation or managing enough so that the surgeon can proceed, that feels like a failure because it's reflective of what has gone on. And we've got to get our egos out of the way and honor the patient's experience, even though you might be saying to yourself, well, I know that epidural's in the right spot. I'm sure of it. You got to get your ego out of the way and really listen. And I tell my residents all the time, if someone is, the more unlike you someone is, the harder you have to listen, because your brain is going to take shortcuts. And if that looks like your sister or your cousin or your niece, the shortcuts you are going to take are going to be in her favor. But the more unlike you the person is, the more you have to actively listen and work. And I try to teach people tools to do it. So, for example, when I'm going into a room, no matter what's going on, I will do 3 knocks. And I know at the end of that 3rd knock, and my dog's going to get up. But the end of that third knock, that I have to turn on a different part of my brain to listen more intently. There's also a trick called the last letter. So make sure you are listening so hard that you know the last letter of the last word that the person says. In medicine, we are always jumping ahead. Okay, she's swollen, blood pressure's up, she's got preeclampsia. Well, okay, probably, but what else is in there? We're rewarded for those shortcuts in terms of diagnostics. But those shortcuts, when you are listening for something that might be going wrong in someone's care, or what's happening with their pain, or what their fears are, if we are not listening closely and we are jumping ahead, that's where we're going to make mistakes.
I just wanted to jump in for 1 second. Thank you guys so much. I feel like what you're saying is so much about being a great physician, really. It's about being humble. It's about being willing to listen even when you're tired. And what you're saying, Amanda, is almost, to me, implicit bias, because we do take shortcuts.
That is
we
implicit
love,
bias, my friend.
yes,
That's it.
we love to sort of like package somebody as a diagnosis and go, done, on to the next thing. But maybe we're not thinking about the right things. So that's one of the harder things, I think, for us to work on. We really need to do a lot of work to work ourselves out of that. And that's a task that I challenge all of our listeners to do. Something that's easier really is what Jennifer pointed out about the lack of equipment. This should not be an afterthought to have a ultrasound at the labor and delivery suite, to have enough staffing, to have labs, blood bank immediately available. We are rapidly running out of time, so I really want to change course and talk about the prenatal care of these women. Is there anything that is not occurring appropriately? Is there anything that we need to change so that maybe these bigger medical issues could be picked up earlier?
Some very straightforward things. So Mofya is talking about some of the things that are different in Europe. One of the things, in addition, is midwifery care. So the vast, vast majority of births are taken care of by midwives. Midwives are the experts in low risk care. If you are low risk, you should be getting care from a midwife, especially if that's what you prefer. Also, group care. There's lots of evidence in Medicaid populations, also in some Black populations, about decreased risk of preterm birth with centering or group prenatal care. Then on the medical side of things, low-dose aspirin. So many patients are candidates for low-dose aspirin and are not receiving it. And low-dose aspirin to prevent preeclampsia, prevent growth restriction. Almost every first time Black birthing person in this country is a candidate, and yet it's not being done. Anyone who has a history of chronic hypertension, people with twins, there's so many indications for low-dose aspirin that isn't happening. And then also treatment of anemia. So not just screening in the early third trimester for anemia, but screening and then doing something about it. You may write a prescription for iron, but if it upsets someone's stomach and makes them super constipated, they're not going to take it. So you need to actually have interventions that should be part of the care, part of your care pathway. So I'd say on the medical side of things, low-dose aspirin and proper treatment of anemia. And then on the care delivery side, more midwifery care, and then potentially group care, and then cultural concordance. Mofya brought that up as well. And there's a great JAMA paper that looks at newborn admitting physicians. If the admitting physician as a newborn in this country is of the same background, you are more likely to survive discharge from the hospital. So this is not a nice to have. Jennifer was talking about seeking out other physicians of similar backgrounds. This isn't just to make you feel comfortable. It's not just to be a nice icing on the cake. This actually saves people's lives.
Right. This saves lives. Mofya, I wanted to ask you about your prenatal experience. How do you think, we as a system could improve that?
I think that listening to your patients is important, right? And really having is if you start thinking about the issues that we have, social determinants of health, right? You can look at your patient and say, what are the issues? Is it health literacy, right? Do they know what they're supposed to do? Why should I take iron? It's going to make me constipated. But if someone has a health background, they might know why that's important anyway, right? But taking the time to explain that to someone is important. So, health literacy, taking the time to teach your patients why things matter, right? Number two, knowing that socioeconomic background matters. So, saying, you know what, my patient has low resources. Can they actually afford to get the iron that they need? And if not, what can we do to help? Right? There's also language barriers that have been shown to be an issue, right? So if you need an interpreter, you get an interpreter, right? There's many times where just a simple explanation in English helps the patients do so much better. Can you imagine how much we'd do more of if we could actually communicate in the language that the patient prefers, right? I've heard people speak English slowly as if the patient will understand when they need an interpreter. So that would, I think, make a big difference. And also, as anesthesiologists, I think that having a pre-anesthetic clinic before having a child will really help educate mothers as to why we're there. Because a lot of them just think we just put an epidural in, and what the message is you're not doing a natural birth if you're having an epidural. What they don't know is before OB anesthesia existed, especially neuroaxial anesthesia existed, women were dying quite a lot, because if you needed a C-section, guess what? You are being intubated, which we know has high risks. So you have a higher risk of aspiration, basically having food and things going to your lungs, right? But they don't know what the implication that is. We tell them not to eat if they're showing up for a scheduled C-section, but they just think we're just mean doctors. We don't not letting that pregnant lady eat, right? They don't know that increases their risk of death so much, right? So like just literally taking the time to really meet our patients where they are and understanding what their barriers are, whether they have a support system, can they get to their appointments, or we have the term non-compliant in medicine, which I absolutely hate, but we don't ask as to what are the barriers so my patient is not doing what I'm saying or what we're recommending. They just, there are reasons versus labeling them. And we also need to remember that we shouldn't put things in patients' charts that would increase bias against them. So all those things, I think when we're signing out, do not start your sign out with that is a challenging patient, right? That is your personal experience with them, but that doesn't need to be in the sign out, right? So like little things like that, I think we could make a huge difference in just doing those things.
Sounds great. Well, we are running out of time, which I am quite bummed about because, like Amanda said, we could talk about this for like 3 times as long, and I think we would learn so much. But I do think this is a good start, and I really hope that, all of us remember that actually this entire issue intersects with just being a good doctor and being good an anesthesiologist. And I also love what you guys all said during this conversation about actually just being a really good team. OBs and OB anesthesiologists working together, both in the prenatal space and in the intrapartum space, to listen to these patients, to pick up on the signs earlier rather than later. I think there's a lot of work to do, but thank you all for participating in this conversation, because I think to name the problem and to name the different aspects that we need to work on is a good way for everybody to start getting engaged. So I would like to thank all of you again for being willing to putting the time for this conversation. This is Vital Times, the podcast for the California Society of Anesthesiologists. I'm Dr. Ludwig Lin. Thank you for listening, and take care. Thank you.